Welcome to From Bench to Bedside, a podcast where science meets real-world medicine and complex health topics are explained with clarity, context, and evidence. Before we begin, a quick reminder. This podcast is for educational purposes only. It's not intended to provide medical advice, diagnosis, or treatment. Every individual's health situation is different, so for personal medical questions, please consult your own healthcare provider. With that said, let's get started.
Talk to me, Goose.
How was your day?
Long. Both of us are so busy, which is good. I like being busy.
We're doing this after a long work day, and it's been very cold, my friends.
I'm unfortunately very good at giving myself things to do if I don't have enough to do.
That's true. Oh, but we have a doozy today to talk about, don't we?
Yes, we have the childhood vaccine schedule and the changes. And we are excited to give you our perspectives on From Bench to Bedside. My name is Dr. Melanie Matthew. I'm a PhD in immunology, so I can give you the scientific perspective. And my husband here,
Dr. Zachary Rubin, allergist, immunologist, and talking about the clinical aspects as it's relating to pediatrics, especially with this type of topic. I think it's relevant that we discuss this, and you've probably heard a lot about it on the news lately.
absolutely. And I'm sure there are so many concerned parents and just people in general who are concerned, who are like, well, wait a minute, did I get vaccines I didn't need? Why is this schedule change happening now? What does it mean? What's going on, right? You know, it went from 17 recommended vaccines to 11. And just to be clear, the vaccine recommendations have never been a mandate.
That's right. They have been a CDC recommendation that's meant for public health guidance. And yes, insurance coverage is dictated by it. But from a state-by-state basis, that's where if there's going to be a specific mandate, it comes from that, not from the CDC itself. So there's an important caveat there because a lot of the framing that you're hearing on TV, on social media, from several of the leaders of our federal public health agencies, they're framing it in the sense of medical autonomy or medical freedom.
Right. And people were not necessarily being forced by anyone to take these vaccines. There are so many exemptions. We're seeing measles come back across the United States because we are below the herd immunity threshold for MMR vaccination for children entering school. And we have been for several years on average across the United States. In fact, I was looking at Colorado today because there was a firsthand account, a report of measles being diagnosed in Colorado. It hasn't shown up on the CDC website yet, but I saw it come across social media. There are 5 counties in Colorado where the vaccinated population meets the threshold for herd immunity. And Denver and Boulder are not one of them.
That's really problematic. So nationally, it's roughly about 92% of kindergartners have been vaccinated for measles, mumps, rubella. And so herd immunity is a threshold where a community needs to be 95% vaccinated. So once you start going under 95%, there's risks for outbreaks to happen. And so this means that some counties have higher numbers, many have lower numbers. And we see a big outbreak right now in South Carolina. There have been at least 646 cases confirmed as of the time of recording this episode. There's likely going to be a lot more, and we're likely at this rate going to eclipse the numbers from even last year in 2025, where we recorded about 2,242 cases.
And we are probably about to lose the measles elimination status that we've had in the United States for over 20 years.
Since 2000. So
Since
it's been
2000, so 25 years.
Yeah.
Time flies. Those last 5 years are busy. So we are about to lose that measles elimination status. And one post I have currently pinned on my TikTok is that even if you've been vaccinated, you can still get and transmit measles. Now, the rates are significantly lower, but when you're exposed to someone who hasn't gotten a vaccine, they have a lot of virus coursing through their system because their immune system, it's brand new for them and it has no way to control it. You know, you can do this experiment with animals in a lab too. You can overwhelm vaccine protection if you give a really high dose of a virus. Your immune system cannot catch up in time. And of course, you know, vaccines aren't 100%. Different people have different levels of responding to a vaccine. Some people may unknowingly be partially immunocompromised. And so to drop below herd immunity threshold and to have this spreading continuously in our population means everyone's going to get to find out exactly how good their vaccine interacted with their immune system, which is a little scary. It's not what I want to find out.
And that's not what I want to find out either. I'd like to transition us into giving a better understanding of how vaccines are approved and recommended in the United States to make sure that everybody's on the same page.
Yeah, absolutely.
So when a vaccine is developed, it first has a bunch of pre-licensing clinical trials that are done for safety and efficacy. And so when a new vaccine comes out where there hasn't been a previous version, there will be a placebo-controlled trial. One of the most recent ones is COVID-19 vaccine, but all the vaccines that have been put on the schedule, some version of that vaccine has had a placebo-controlled trial, meaning one group would get a vaccine, the other didn't, and it would not have the active ingredient, and they would randomize those kids to the point that the families didn't know what they were getting, the people giving it wouldn't know what they're giving to reduce bias, and then that data is collected over time and then sent to the FDA for approval. And so there are multiple layers to that initial approval. Once that does get approved, then the CDC has an independent advisory committee on immunization practices called ACIP that would meet to discuss the data and decide how would they recommend this vaccine on the schedule itself. Once they give their formal recommendations, the CDC director would look at it and sign off on it. That's the general bird's eye overview prior to the current administration coming into power. When RFK Jr. came in last year, he fired everybody on this independent panel and replaced it with people that he picked of his choosing who were not necessarily the most credible people.
So the name of that panel is ACIP, or the Advisory Committee on Immunization Practices, and it was a 17-member committee before. These people have been vetted very well. They were professors at universities, MD, PhDs who'd spent their careers studying vaccines and how vaccines interact with the human population, the epidemiology of vaccines. They'd spent a long time going through clinical trial data, and these vaccines never landed in front of them for a recommendation vote without prior FDA approval. So these vaccines have already been vetted. They'd gone through safety. They'd gone through efficacy trials. And then the question was, do we think that this is good enough and important enough to recommend to the United States population such that insurance companies would have to cover it and protect people from getting these diseases? So there could be, I can see some areas for potential conflict of interest there, but every single member was vetted for this. Every single member had disclosed their conflicts of interest, and they were independently vetted as well. And there were, of course, a couple conflicts of interest, right? Because the world is small, you have only a few experts in these areas, and they were required to recuse themselves, step away, and not vote on these recommendations whenever there was a known conflict of interest. So there's a very stringent process. A 17-member committee is, you've got to come to a pretty solid consensus. And one thing I loved about the ACIP meetings before that 17-member committee was gutted and replaced with absolute non-experts. Like, we can go through every single one of their credentials, but truly none of them can hold a candle to even just one of the 17 members that were on that committee before. They have no business being there, truly. But what I loved about the meetings before was that they would publish their agenda, ask for and accept public comment for and against all of the topics they were discussing. If you'd ever listened to ACIP meetings and you were a nerd like me, you heard for and against arguments from the public. They would bring in outside experts that were well vetted. They stayed on schedule. They had really data-rich presentations from the CDC, from pharma companies, and they would grill those pharma executives for all the right data. And all of this would be published well ahead of time. And now it's just like a circus, The prior committee head would spend a good half hour to 45 minutes complaining at the start of every meeting about his own personal career and how he'd gotten fired.
It was highly inappropriate.
It was wild. It was a waste of everyone's time. Super embarrassing, not on topic. Like, That's just one example. I could go on. Sorry, you brought up a sore subject for
I
me.
know.
It's a wildly unprofessional
But
group of people at the
I,
moment.
I want to make a point with something you just said there, which is the fact that the disorganization that's been happening lately is astounding.
I've seen high school debate teams run a tighter process.
There was a point that you made there that was really important, which is the level of disorganization is astounding. So we could 1 to 2 weeks before a meeting see their meeting agenda, the people who are presenting, the PowerPoint slides that contain the data, an entire data packet that you could review well in advance. And what has happened over the past 12 months is that half the presentations wouldn't be uploaded even while the meeting was taking place. This was a situation where they would claim radical transparency while actually not being
Yeah.
transparent at all. And
It's the
so,
first time I've ever seen on the ACIP schedule TBD for a speaker and a topic. And they would just throw someone up like the day of or like the evening before. It was
Right.
awful.
right. And the voting questions that tells you what they're going to recommend would often not show up until the day of, or they wouldn't even be able to vote on. In fact, the hepatitis B vaccine birth dose was delayed by a meeting because they couldn't agree upon the voting language that was set forth. And many of the committee members didn't even know what they were voting on, which is highly problematic. And it's gotten to the point where they had their initial, what they thought of as a win, to say that the first birth dose of hepatitis B vaccine could be optional if mom tested negative for hepatitis B surface antigen. Now, keep in mind, hepatitis B is an infection that can cause, in 90% of cases, chronic liver disease in children, which can be life-threatening and life-shortening. You can have cirrhosis of the liver. You may need a liver transplant. It's a devastating, preventable disease where over 90% reduction in infections occurred once we made the change in the 1990s to make this a universal single dose. And their argument was essentially saying that other countries don't do it this way, therefore we're okay. But the United States is very different. And what's really irked us is the fact that...
Well, hang on. Let's clarify what you're saying here, because the United States isn't that different from many other countries that still recommend Hep B at birth. They just cherry picked a very tiny country with an entirely different health system, Denmark, and they decided that they want to try to mirror a 6 million person country's vaccine schedule where everyone has universal health care and they get the vaccines anyway. The timing is just a little different. It was ridiculous.
Well, also the epidemiology, the demographics of the disease transmission rates are vastly different. But this is the excuse they give to then decide that they went above the ACIP and they had two different people write a paper to justify changing the entire CDC schedule, not just hepatitis B. But now we're going to get into what the dramatic changes have been that could be potentially very, very challenging for many folks across the country.
Hang on. And I'd like to add the kids in Denmark, they may not get Hep B at birth, but they get it at 3 months. And to follow a child and ensure that they get that Hep B vaccine, it's kind of hard when you skip it at birth. And when those kids get that Hep B vaccine is right about at the end of Denmark's maternity leave. This is important, and I wanted to mention this because Hep B is not just a sexually transmitted disease, as some people have tried to state. It is transmitted through blood. It is highly contagious, about 100 times more contagious than HIV. And as Dr. Rubin said, major cause of liver disease and liver failure in young adults if they are infected as a child. And so what can happen is in our country, women go back to work a little earlier, and those kids are suddenly put into a daycare situation where a very tiny drop of blood can be on a toy and it might not be properly disinfected and it goes into their mouth, or, a caregiver has a sore on their hand and it's a tiny speckle of blood to those children and they may become infected. And so the timing of that vaccine for women in the United States is actually very good at protecting those children from getting sick. And HHS knows this. On their own website, They list hepatitis B as a contagious viral infection of the liver spread through contact with infected body fluids such as blood and semen. And it causes chronic liver infection, liver failure, liver cancer, and death. It's not great to see a 22-year-old who needs a liver transplant or an 18-year-old, right? That's about the age when you start to see this virus really take hold and impact people's lives.
So one other additional issue about Denmark that we don't have in the United States is the fact that not only is it a nationalized healthcare system, it's centralized in their record keeping. So in the United States, we don't have that ability to track patients nearly as easily, especially because it's a much larger country with a fragmented healthcare system. Many people fall through the cracks, and the testing is not always accurately done. Some people don't get the testing. And so this is going to create a lot of additional paperwork and confusion that some children, it may not happen right away, but some children may end up having problems as a result of this.
Absolutely.
So let's talk about the new vaccine schedule that they have recommended and why it's so problematic.
Right. So they used to recommend vaccination against 17 pathogens. Now it's 11. There are no more at birth or 1 month old vaccines recommended. If you are in certain high risk groups, they do say that at birth you can get hepatitis B. That's likely if the mother is infected and that's known, or
it's not a universal recommendation.
They say, okay, wait. So for certain high risk groups, they still do recommend a couple at birth vaccinations. So for Hep B, it's still recommended for infants born to women who have tested positive for the Hep B virus or whose status is unknown. That is also problematic for the reasons that Dr. Rubin was saying about centralized record keeping, because women get tested for Hep B when they're pregnant. Sometimes, most of the time, maybe, but it's only in the first trimester and they can acquire it, right?
Yeah. And
pretty easily.
And roughly 15% of pregnancies in the United States are not tested for hepatitis B.
Yeah, so that's quite a few. And then for some high-risk groups, they still recommend RSV monoclonal antibody at birth through 7 months old.
Which is a complete reversal of what they had initially recommended, which is saying that all babies get 1 dose for their first RSV season and then a second dose during their second season if they're at high risk. So that would be like a baby who had a cardiovascular problem like congenital heart disease, or they have chronic lung disease. This is a clear departure from that.
Yeah, I agree. So what the new recommendations are and what they consider high risk are all children whose mother did not have the vaccine for RSV should get a dose. And then high risk children, such as those with chronic lung disease, should receive a second dose at ages 8 to 19 months.
There's also a whole nother category called shared clinical decision-making, which, in my opinion, as a pediatric specialist and one who have counseled numerous families about vaccines, it's really gaslighting what pediatricians and other primary care physicians like family medicine physicians do, which is we provide informed consent. We have conversations with our patients and talk about the risks and benefits of vaccination. And what this signals is saying that doctors don't do this, which is not true. Putting these vaccines into this category is not helpful and can be potentially harmful. And we're going to list off here the vaccines that they put in that category, which includes rotavirus, COVID-19, influenza, hepatitis A, hepatitis B, meningococcal ACWY, and meningococcal B. And so I want to talk about rotavirus because that is the one that really irritates me quite a bit. And I hate to say it that way, but it really does, because that is one especially where, since my training, I have not seen a kid hospitalized from rotavirus. That was something that my dad, who's a pediatrician, used to admit kids all the time for. Rotavirus is a highly contagious virus that causes severe diarrheal disease, leading to dehydration. And what I hear on the news from RFK Jr., our HHS secretary, Marty McCary, who is the FDA commissioner, they constantly distort the reality of the statistics involved with rotavirus and the rotavirus vaccine and say a lot of misleading statements about it to justify making that vaccine essentially optional. So they made the claim multiple times that only 3 children in the United States would pass away from rotavirus each year prior to the vaccines coming into the market, and that the vaccines brought it down to 2 deaths per year, which is not true. It's roughly 20 to 60 kids would pass away each year. And we would have about 500,000 doctor visits each year due to this viral infection. We'd have about 250,000 ER visits each year, and about 50 to 75,000 infants and toddlers were hospitalized because of dehydration.
Right. Which is actually a little more scary than it sounds. Like people walk around and they're like, I'm dehydrated, drink some water. Oh, I'm not feeling good. I have a headache. I'm dehydrated. No, no, no. These children can't keep fluids down. It's coming out of them faster than you can replenish it. And they have to have IV hydration, and it can do horrible things to their colon. And this vaccine has reduced hospitalizations by about 80%, right? That is truly phenomenal. Like as a parent, I can't imagine having my kid hospitalized for days. They cannot keep the fluids in, right?
It's quite severe. And having taken care of many children in the hospital in the past, no parent wants their kids in the hospital. And the messaging that's coming out of our federal public health agencies is basically downplaying the risk by saying, well, only 3 kids died a year and it went down to 2. And they completely ignore the reality of not just mortality, but morbidity as well, which is the severity of living with the disease. We know that children who are hospitalized are at higher risk of developing symptoms of PTSD, as an example. Dehydration also carries the risk of kidney damage. It's not something that you would want any child to go through. I think any reasonable parent would agree with that.
Yeah, absolutely. And it kind of just blows my mind that they go on these press tours and they're like, only 3 kids died. And then everyone starts repeating this when on their own website with their own data of the agencies they oversee, it says 20 to 60 deaths.
And even then, no child should die from preventable illness. The vaccines have been so effective that there have been entire wards of hospitals closed down because they didn't need to staff them since there weren't nearly as many kids getting hospitalized. That's how effective vaccines have been. So if you haven't worked in a pediatric hospital, it's hard to conceptualize what that is. Or if you've never seen a disease like rotavirus, which rarely happens at this point, but by allowing this to become optional and creating this mixed messaging, it's not going to increase vaccine uptake. It's just going to cause further confusion and doubt, and will likely decrease vaccine uptake in an ecosystem where trust is at a premium and the people who are in positions of power are giving such mixed messaging. So there's one issue that I want to talk about too, related to how they distort the reality of rotavirus and the rotavirus vaccine. The original rotavirus vaccine that came out was called RotaShield in the late 90s, I believe 1998, where there was a small increased risk of a complication called intussusception, where the intestines would telescope on each other, and that would cause a little bit of oxygen loss to the intestines and can lead to intestinal bleeding. And I never saw it due to the vaccine in my career, but occasionally I would see cases. It just happens sporadically. So I understand, how severe this type of disease can be. But what they were trying to frame this in justifying their recommendations is saying that this vaccine is not safe. The newer vaccine is called either Rotarix or Rotatec. It's not the same product, which does not carry the same higher risk of developing intussusception.
Right. And it was only like 2 or 3 kids per 100,000 in the prior vaccine.
Correct.
And the current one, what's it called again?
Rotarix.
Rotarix. And now it's about 1 in 100,000, which is significantly lower than any of the complications a child may have from the virus itself.
Exactly. Again, 50 to 75,000 kids would be hospitalized from severe dehydration. 20 to 60 would die.
Yeah. And that's not a deadly complication, right? It's recoverable. It lasts for
intussusception.
Yeah.
Yeah. There's proper treatment for it, pain management. Sometimes you have to give an enema to fix it. But the way that they've been framing it has been intellectually dishonest, to put it mildly.
Absolutely. And dangerous for children. Seriously.
Not to mention some other vaccines, which we've talked about previously, like influenza.
So those are just a couple of the vaccines that have been changed on the recommendation schedule, but let's go through the list. So, if anything pops out to you, Dr. Rubin, things you haven't seen because the vaccines have been so prevalent and now they're going to potentially go away, or things that you are particularly concerned about as being very dangerous. So currently, the changes in the vaccine schedule, the CDC no longer recommends rotavirus, influenza, meningococcal disease, RSV, Hep A, and Hep B.
Meningococcal is something that I've seen once in the past. And that was in a teenager who ended up having meningitis, needing a spinal tap, ended up on very serious antibiotics in the hospital for several days, and had permanent hearing loss.
Meningococcal disease, I've told a personal story about this, but I don't know that people realize how deadly it can be and how quickly it can move. So first of all, what happens is a lot of people think they have influenza, and unless you do a spinal tap, it's very difficult to diagnose meningococcal disease. And, we're talking about usually healthy teenagers who are going off to college for the first time, and they're in like a dorm room situation where it can spread very easily. There's bacterial meningitis, there's viral meningitis, and there's even a fungal meningitis. But we're talking about bacterial meningitis here. And someone I went to high school with who had all the resources in the world, very sad story, lovely girl. Her freshman year of college, went to the ER, thought she had flu. They sent her home and back to her dorm room, and they found her dead. She died.
Gross.
And that's how quickly, 12 hours later, she was dead. That's how quickly this infection can move. And even if they catch it with that spinal tap, people can have permanent hearing loss. Amputations happen while they're trying to save your life because you go septic and you start to lose limbs and toes and fingers. And these are people, young people, just starting out their lives. But that vaccine may no longer be covered by insurance companies because of these new recommendations, by the way, which I don't think we've mentioned, are not based on any new data.
Absolutely.
There is no new safety signal that indicates that these vaccines should be pulled from the market, shouldn't be recommended, aren't doing their job as we understand them to be doing their job, which to me is unconscionable.
These decisions are clearly policy and politically driven, not from an evidence-based perspective, because we have yet to hear of a new study where there is a clear safety concern about any of these vaccines that we have been talking about, where the risks outweigh the benefits for the general population. And we've talked about shared clinical decision-making earlier. Doctors still do that. We've been doing that the entire time. And there are clear medical exemptions where not everybody can get a vaccine. But the whole point of having general recommendations is to make sure that the general population has a high enough vaccination coverage to create herd immunity, which means that those who are unable to get vaccinated or those who do not mount a proper immune response without even knowing it get protected. I, on a regular basis, see patients where they have to get their titers drawn, where antibodies are drawn from their blood, and they measure it to see, did the vaccines cause a protective immune response? And there are times where healthy people are walking around, they get this blood test, they find out, oh no, they're not immune to a specific disease. And then we have to decide, how do we work that up? And sometimes we'll give them boosters. And even with boosters, there are rare instances, which I've seen, where a child or an adult will just not make a proper response for all sorts of reasons. And so to protect those people as well, they wouldn't even know it. There are cases from time to time where people did everything right and still can get infected because no intervention is 100% effective. But if we do risk mitigation, we lower the risk, we can cause a lot of good protection and success from the population level, which is the whole point of public health. And the federal public health guidance is supposed to help entire populations, not make this about an individual or somebody who's complaining about this themselves. It's about the greater good.
Absolutely. And, Dr. Rubin, you and, tens of thousands of other pediatricians around the United States are so passionate about this because they went into medicine to help children grow up into healthy, happy adults and, pursue all the wonderful things that you get to pursue in life and to avoid those disabilities, to avoid those risks of death. And, it must be so frustrating as a physician to know that there is something that can keep a child well and healthy and, has minimal risk of side effects, and to have people be dissuaded from it to the point where we are now bringing back diseases that you didn't even see in clinical practice or haven't even seen in clinical practice.
I've never seen a case of measles.
Yeah. A lot of physicians haven't.
Yeah, they haven't. So this is highly problematic.
And so with that said, the American Academy of Pediatrics has put out a vaccine schedule as an answer to this kind of rogue ACIP and CDC that is making recommendations that are not data-based and don't protect children the way that they could be. And that can be found online. We'll put it up on the screen here if you're watching along. And if you search for AAP, and that's the American Academy of Pediatrics, immunization schedule, you'll see one that is a recommended child and adolescent immunization schedule for ages 18 years or younger for the United States, and that's freely available, downloadable. We don't give medical advice. Take this to your pediatrician. Ask them all the questions you have. They are there to answer those questions. They are passionate about keeping your children well.
Keep in mind that this is also a state-by-state issue now, because many states, like we are in Illinois, are starting to rebuke these federal public health guidance. And so depending on the state you live in, they may still follow the AAP or a previous CDC schedule prior to RFK Jr. changing everything to the beat of his own drum.
Absolutely. And shout out to the West Coast Health Alliance, where my home state of California is home to some of the greatest science in the world, truly. And some of the best universities in the world are there. And people are outraged that they're fiddling with public health on such a massive scale. These children don't have a choice. And maybe some of their parents don't have a choice if their insurance companies decide not to pay for it. They don't have the extra $200 to $400 to $600 laying around, to get those children vaccinated. And so, I'm really glad that, a lot of governors have enough foresight and enough understanding of science, public health, and medical interventions that save lives to actually put together these recommendations and stand up to, what's happening at the federal level. But I want to ask you one more question, Dr. Rubin. As a physician, have you ever seen a vaccine adverse event? Because we're not here to tell you adverse events don't occur. We're here to explain to you what the actual science is behind it and the rates that you actually see. So have you ever seen one in your clinic? What did it look like? How did it happen? What was the follow-up? Have you ever had to make a VAERS report? Let's go through it.
Yeah. So it's actually detailed in my upcoming book, All About Allergies. I have a whole chapter dedicated to medicine, medication, and vaccine allergies. And so when the COVID-19 vaccine came out and was rolled out in late 2020, early 2021, there were reports coming out, especially on the West Coast, where there were people reporting episodes of anaphylaxis to the vaccine, which is a severe allergic reaction. And then there were a lot of reports of, they called it COVID arm, where people were getting these large swellings that were happening. So I saw quite a bit of that, the large local reactions. In fact, one of my patients was interviewed on national television.
Interesting.
To talk about that. Yeah, I referred them to, I can't remember which outlet it was, but they were on TV in Boston, actually, talking about this.
Okay, so Dr. Rubin, what is COVID arm? Because I never personally experienced that. I don't know anyone who did. Yeah. So what was it? What happens with COVID arm?
So here's the thing. Theoretically, any injectable medicine could theoretically create what people had referred to as COVID arm, which is, in the allergy world, we call it a large local reaction, which usually is due to a delayed T cell response. that causes,
Is it like a delayed type hypersensitivity response?
most
Like
likely,
a DTH?
what's often referred to as type 4
I was going to say
hypersensitivity.
there's 4 types of DTH, maybe a 5th if you really want to get weird about it.
We're not gonna
Because
get
the
into
immune
the weeds of
system
that.
just gets weird sometimes.
But the point
Let's be real.
is that the immune system has a delayed response that causes localized swelling where there's increased fluid buildup, redness, you may have some itching or burning sensation, not an increased risk for anaphylaxis, which is the systemic allergic reaction.
And it might feel like kind of hot, right? Like more
Burning, yeah.
cytokines being there,
Right.
being released
it's-
there. But it's 48 hours or so. It's a pretty quick one.
It's treatable.
Is it the same thing as a nickel reaction?
It kind of looks like it, but it's not quite the same mechanistically. The point is that it's treatable.
The immune system is really cool. And something like a DTH type 4 can happen for a lot of reasons. It's usually self-resolving without any long-term issues, right?
Exactly.
Yeah.
And so this typically happened in the first or second dose and wasn't always reproducible. So you could have it, and that's something that we learned over time. So that was fairly common for someone like myself who ended up being one of the go-to specialists in our community because very few people were really staying up to date with it and seeing patients. And I was collaborating with allergists out at Harvard at Mass General Hospital. And so this is where we get into the more serious adverse events that I actually have seen. So I had a patient who was an ER nurse who got her COVID vaccine and within a couple of minutes developed some severe difficulty breathing, wheezing, and hives, which is concerning for a potential severe allergic reaction known as anaphylaxis.
So a lot of women can't wear earrings with nickel in them, right? Because it makes your ears fill up. It's kind of itchy. It's reaction. That is the same type of immune response. You take away the stimulus and it self-resolves and you don't have any other issues.
Exactly. So now let's talk about some serious adverse events that I have seen, which are very rare. I want to make that very clear. So when the vaccines were being rolled out, there were some reports of severe allergic reactions. There was anaphylaxis. The initial guidance was to say that people would have to wait 15 minutes after their vaccine to detect this and 30 minutes if they were considered potentially higher risk. And so I had a patient who was an ER nurse who got her vaccine in the ER and within a few minutes developed difficulty breathing, wheezing, and hives. And was given epinephrine.
Is so scary, right? Like
Absolutely.
I agree. This is like scary stuff.
And was given epinephrine. I mean, she's in the emergency room, that would happen. And her symptoms resolved. She recovered without any complication afterwards. It was very scary. So she came and saw me. And at the time, I was looking into the literature about what do we do about this? Because this is a newer vaccine and we're in the middle of a, once in a generation, once in a lifetime type pandemic. What do we do? And there was some guidance coming out of Harvard talking about doing some skin testing for the different components of the COVID-19 vaccine. So there's a component called polyethylene glycol, which is in different molecular weights that you have to look into. There's polysorbates. There's the active ingredient itself, right, which is the mRNA. And so we had to come up with a protocol to do skin testing to see, are there any of these components showing up?
So polyethylene glycol is the long form chemical name for something called PEG, P-E-G. And PEG can be found in so many things around us.
Like Miralax.
Miralax, right? Makeup products.
Yep.
PEG is pretty ubiquitously used, and there are known sensitivities to PEG.
Yes.
And so you have to remember when you're vaccinating an entire population and there's an ingredient in that vaccine with known sensitivities, you would expect someone to have a response to that, right?
Absolutely. So I did the skin testing based on the Harvard protocol and nothing came up positive.
Interesting.
And so while I was doing this, there were other allergists working at the same time on similar cases. And we came up with this idea that it wasn't the same type of allergic reaction that would normally require epinephrine, actually.
Interesting.
So when we think about food allergies, you could have an allergic reaction requiring epinephrine, and that's due to having an antibody called immunoglobulin E, or IgE for short.
Hmm.
And so 1 in a million chance for other vaccines, you could have an IgE mediated severe allergic reaction. That's
Right. And
typically
that's actually the data I'm looking at right now. So again, we don't want to say there are no adverse events with vaccines, but it sounds like, Dr. Rubin, the only time you've ever seen one in your clinical career is with COVID vaccines.
correct. The other
Okay.
vaccines, I've never seen it, but I have seen hives with the DTaP vaccine.
Let me review some of this data right here. So I'm looking at a study that went over all patients with a vaccine record from January 2009 to December 2011, adults and children, and they found out of 25 million, 33 confirmed cases of vaccine-triggered anaphylaxis, which, as you say, breaks down to about 1 in a million or so, just slightly above 1 in a million.
Right. And so the only case of anaphylaxis was this one that I'm talking about. But based on what we started discussing amongst ourselves in the allergy community, we believe that the vast majority of these cases were from what we call a pseudo allergy, where it looks like the classic severe allergic reaction, but it's not mediated by the protein IgE.
Mhm.
And therefore, because it's a pseudo allergy, you can actually pre-treat and prevent it from happening, which is what I did for this patient who was an ER nurse who wanted to continue working, who wanted to do her part not only to protect her patients, but her family members.
Mhm.
And so we did a protocol that I came up with in terms of loading up with steroids,
Mhm.
antihistamines, and she was able to get subsequent doses without that ill side effect.
That's fantastic. So was that then not a true allergic response?
So a pseudo allergy is still an abnormal immune response. It
Mhm.
just follows a different pathway.
So, Dr. Rubin, this was an unusual immune response, not even a true anaphylaxis that you saw.
Right. So a pseudo allergy is where you have what looks like an allergic reaction. It's an abnormal immune system response to a foreign substance, but it's not caused by the IgE antibody. And because of that, you can actually pre-treat and potentially prevent the reaction from happening, which in the case that I had, we did that. We pre-treated with steroids and antihistamines, and the patient was able to get the vaccine successfully without significant side effects because she wanted to get vaccinated and have full coverage at that time because she's an ER nurse. She wants to protect herself and her patients, but also, most importantly, her family.
Yeah, absolutely. So that was a real occupational hazard for her, which is actually one of the reasons why I update my Hep B vaccine every 10 years, because I often work with human samples to look at their immune cells.
Right.
And that is a risk, right? There's a risk of infection there that, when you're working as a scientist or a physician, you've become very familiar with vaccines. You need to protect yourself, I also have worked in research centers that have been attached to major hospitals. So every year we were also told we should probably get our flu vaccine, right? Because we'd be exposed to the seasonal influenza. And we did.
And in hospitals, we're required to get influenza vaccines and make sure that we're up to date because it's an occupational hazard. As you said, you have to protect yourself and your patients and your family.
So I know this is anecdotal, Dr. Rubin, but not everyone gets to hear from their doctor that, first of all, they've never seen an adverse vaccine event except you with the COVID vaccine. And it was one person that you guys, aside from COVID arm, which self-resolves and is kind of a well-understood immune response, one person that you were able to develop a protocol for and continue to get her vaccinated so she could do her job as she wanted to and feel protected. But how many cases of vaccine preventable illness have you treated or seen in the hospital?
I have seen no measles.
You've seen no measles.
I've seen no rotavirus in the hospital.
Okay. Which are commonly recommended childhood vaccines.
Right. Influenza B, which is probably one of the scariest ones.
Why
I
is
read
that one so scary? Let's pull up that one?
Because that one can cause not only meningitis, which is inflammation of the meninges, which line your central nervous system, like your brain and spinal cord, but it can cause something called epiglottitis.
Wait. Now, hang on. Why is the swelling of your meninges so scary to a physician? Tell us why. What can happen?
Because meningitis can lead to not only you getting very sick, but you could have permanent disability and it can cause death because that type of inflammation can affect your brain. And as I mentioned before, I had a patient who had permanent hearing loss after having meningitis. That is something that can happen. I've had a patient who was in their 70s who got meningitis as a child and has had countless numbers of surgeries in the ear to try to get hearing function back.
Wow.
And there's another complication called epiglottitis that H flu can cause. That's where
Really?
there's swelling of the epiglottis, which is the flap that covers your airway when you eat, so you don't swallow food in your airway.
Oh, wow.
And that type of inflammation causes a swelling. There's an x-ray, which I'm going to show right here, that essentially closes off the airway and children suffocate from it. And I've never seen it,
Terrifying.
but I've known of cases and I've had colleagues and mentors who have seen it. It is one of the scariest things you could see a child go through.
Wow. That's pretty terrifying. Do they have to intubate or does it happen quickly?
This is something that they can decompensate very quickly. And so the management depends
so
on...
decompensate, let's define that for everyone people who haven't worked in a hospital.
So the issue is that if a child has trouble with their airway, they're more likely to die. So,
right. So decompensation means they're just headed downhill fast,
right.
medically
Their
speaking,
vital signs
right?
and everything start tanking.
Yeah, it's that
and
moment like you see in the hospital shows where the crash cart comes rolling in and people are like, move,
Right.
shot of this, shot of that, clear.
The airway in children is, if that goes, then the heart goes.
Right.
So
It's the ABCs of first aid, right?
Yeah, but when we talk about children versus adults in terms of their overall health, when you have a severe decline, typically children start off with respiratory problems that lead to failure that then causes your cardiovascular collapse.
Right.
Versus adult
ABC
patients,
is airway,
breathing,
circulation.
Right.
But that epiglottis covering the airway, everything else goes, right?
Correct. So it's not something that I wish for anybody to have to ever see again. And luckily they didn't change that as a recommendation on the vaccine schedule,
influenza B,
because I can almost guarantee you that there would be a huge uproar if that was not recommended because of how scary that it can be.
Yeah, and they seem to be steering away for the most part from things that would cause a massive backlash. Like there already is backlash. Don't get me wrong. Like states are going their own way, forming their own coalitions. Pediatricians are up in arms and not pleased with the way it's going. ACIP is basically a clown car and a revolving door all in one right now. And nothing is data-based anymore. It's just they've gone rogue. But I did hear something today that did seem like a third rail. So let's talk about what was said about the polio vaccine.
Yeah, I'm actually going to pull up a quote to make sure that I have this because it was terrible. The current chair of the advisory committee on immunization practices is a pediatric cardiologist named Dr. Kirk Milhone. And he was on a podcast recently talking for somewhere around an hour about the role of the ACIP with the current vaccine decisions, which they didn't make the latest vaccine decisions. That was up to a couple of other people outside of the committee, but that's besides the point. He had a few quotes. As you look at polio, we need to not be afraid to consider that we are in a different time now than we were then, he said. Our sanitation is different. Our risk of disease is different. And so that those all play into the evaluation of whether this is worthwhile taking a risk for a vaccine or not.
Whoa.
He also referred to vaccine requirements as authoritarian, but rejected the label of being known as an anti-vaxxer.
So polio was eradicated in the U.S. in the late 1970s with widespread vaccination starting in the 1955-ish time, okay? he is indicating that he didn't think modern sanitation was in place in the 1950s through the 1970s. We still use a lot of the same infrastructure that was established at that time, the same sanitation procedures effectively.
Exactly.
It's not
And
like we didn't put chlorine in the pools in the 1970s. Like, that existed.
our current medical practice would not be able to prevent paralytic polio. So if you get polio, there's a risk of paralytic polio.
Exactly. Like, there's no way to say, oh, this person has polio, let's put them on this course of treatment
Correct.
to prevent paralytic polio from occurring.
Right. So his arguments make no sense. And it gets even better. He said that the ACIP is shifting its orientation, quote, "We are returning individual autonomy to the first order, not public health."
Wait, what does that even mean? The first order of what?
So first off, when I heard that, I thought he was talking about Star Wars.
I know, like, what is he
That's
talking?
what it felt like when I heard that. I crawled inside and felt like I was crawling in my skin. And so what I believe he's trying to say, which is what we've been referring to earlier in the episode, is that the way that RFK Jr. has set up the committee and his directives is to change the conversation about vaccination amongst the population as not being a public health issue, but being a medical freedom, medical autonomy issue. This is the issue we've been seeing since the beginning of the COVID pandemic that was talking about conflating the my body, my choice. That's really about being pro-life and saying, I'm not going to wear masks and I'm not going to
I
vaccinate.
hate that conflation. That conflation
terrible.
is a terrible analogy.
But you see where I'm coming from, right?
Pregnancy is not contagious.
Exactly.
I really do not like this my body, my choice conflation of vaccines because pregnancy is not a contagious disease, right? And so we all need to have agency and medical freedom to make choices. However, when it comes to public health and you live in a society that has people that cannot get vaccinated truly or has children who are immunocompromised, that medical freedom is dependent on you being a responsible human being and avoiding the spread of highly contagious diseases to everybody else. Like,
Right.
it's the reason why things like smoking indoors has been banned. You may want to make the choice to die from lung cancer in your 50s or your 60s, and that's fine. Maybe you'll live till 90. Who knows? It's less likely. But you don't get to have the freedom to make sure that everybody else suffers for your choices.
Right. That's why most restaurants won't allow smoking unless you're in a casino, as an example.
Right. Right. And so, there are known medical risks associated with this, and you don't get to just cause other people to have a horrible life through your choices. That's when living in a society and the rules of living in a society become important. Listen, if you are never going to see another human being in the world, sure, like, go ahead and die from a preventable disease when you're 25. But you don't get to spread it to everybody else on your way out.
There's one last quote that I want to talk about because it's so crucial to what we've been talking about throughout this episode.
Mm-hmm.
He said, "I don't like the word safety. Safety is not a scientific word. Safety is an emotional response to risk."
What?
This is the type of wordsmithing that you hear from RFK Jr. that's obviously being handed down to the chair of the ACIP. It's this dancing around with wordplay to try to convince people that vaccines are not properly safety tested.
Like they test things for safety and efficacy.
Exactly. Safety is
An emotional response. Yeah. I want to hear that again. Safety
is an emotional response to risk.
Oh boy. Me putting on my seatbelt when I back my car out of the driveway. Big old emotional response to potentially getting in a motor vehicle accident where I might die. Like, yeah, I don't want to die.
No.
I'm going to put my seatbelt on, and I don't want to be hospitalized or suffer lung damage or organ damage or potentially die or even just have a really crummy couple of weeks
Yeah.
if I could get a vaccine and have, no response to it, which I really haven't had many vaccine responses at all in my life. The worst case scenario is like a fever, but that's about it.
And why he was saying that is because he then says, no, they haven't been appropriately studied for safety. They've been mostly studied for efficacy.
False.
Again, this is what
Wildly false.
Again, this is why this is RFK Jr. speaking, because he said
Boy.
this in press conferences to interviewers, which is this idea that we don't assess for safety properly, which is not true at all. There are multiple studies for pre-licensure purposes where the safety is looked into very closely for the systemic reactogenicity. That's the actual side effects that you get immediately from a vaccine. And you cannot design a clinical trial that is large enough to pick up on the rare side effects, which is why there are post-marketing surveillance studies where you're looking at large swaths of population over time with active and passive surveillance systems, which they have through the Vaccine Safety Data Link and Vaccine Adverse Event Reporting System, which I have filled out before.
Yeah.
Like with that case of anaphylaxis, I've filled it out, but it's a public system, so anybody can fill it out. It's not necessarily verifiable. But I've had follow-up when that happened. I talked with an official briefly about it. But the point is that what they are telling you is far from the truth. We're here giving you the best nuanced information that we can to make sure.
So going back to some data that I brought up earlier, it is about 1 in 1 million serious adverse events for modern vaccines across adults and children. And so to try to look for an adverse event that is as rare or even more rare than that, you can't do multi-million person studies. You might as well just vaccinate people and, as you said, do the post-market surveillance, because that is a very safe medical intervention, honestly. There are so many things that you have more than a 1 in 1 million chance of having a serious adverse event. My earlier example of driving my car.
Exactly.
Right? How many people out of a million have ever been in a car accident?
That's not to say that there aren't some side effects that we talk about. So as an example, about 1 in 30,000 who get a measles-containing vaccine, they'll get a measles-like rash. There's fever that can happen from vaccines, okay? But when we say serious adverse events, that's like what I mentioned before, which is anaphylaxis, as an example.
Exactly. So car accidents that I was talking about earlier, I just looked it up. 12 deaths per 100,000 people. Okay? We all still get in our cars. And a lot of people railed against the idea of ever putting in seatbelts. So,
change is hard for people.
Change is hard. Yeah. People really need to understand the why, but then sometimes the why takes a lot of data and explaining, and taking those seatbelts away, like what we're doing with vaccines. It's going to be really scary for this next generation of children. And you as a physician, and many, many other physicians are speaking up, coming forth, using their voices, using their professional education and experience to try to prevent a generation of children that will grow up with diseases that you have not ever seen in the clinic before.
But we strongly encourage you to actually speak out, to talk with your doctor. If you have family or friends that are concerned or confused, that just having a conversation openly can go a long way, but also talking with your legislators about what is going on and how displeased you are with what is happening. The more that people speak up to our legislators and using your power as a constituent to speak out can make change. We just all have to work hard to get there.
I agree. And, one of the things that feels just ethically horrific to me is that the people recommending these changes, enforcing these changes, encouraging these changes that put children in harm's way are all themselves vaccinated. All right. So, Dr. Rubin, thank you so much for lending your valuable clinical expertise here. Me as a scientist, I have a lot of experience with vaccines. I've even given animals some vaccines. They work.
That's pretty cool.
They do work. And, as an immunologist, vaccines are fantastic. And people are really worried about them. And I think one of the reasons they're really worried about them is they don't really understand what's happening. And so let me just provide an immunologist perspective on that. And that is, it is an educational tool for your immune system. It gives your immune system basically the notes to study for a test, shows it exactly what the pathogen it's going to encounter looks like, or if it's a near miss and you have some mutated version of the virus that comes along, it kind of knows what it looks like. It's like studying for a test with, here are some of the answers, but not all of the answers, and your immune system can memorize them. It adapts very quickly when it's a slightly different question that's being asked on the test, in the case of a mutated virus, and it will work very hard to keep you well. It'll work hard to do its job. And so getting the notes before the test, studying before the test, that's really just what a vaccine is for your body. And so that's why sometimes you get a little bit of a fever, maybe a swollen lymph node. That is your immune system responding to that vaccine and studying for that test. And, I can't imagine and don't want to be in a world where I get knocked out by influenza every couple of years for a couple of weeks because I don't get a vaccine. That just sounds miserable. It sounds like a waste of time. So anyway, thank you, Dr. Rubin, for going over these vaccine adverse events that you've seen and not seen, the vaccine preventable illnesses that you've seen and not seen.
It's my pleasure. And it's always important to talk with your doctor if you have questions or concerns about any medical intervention. That is truly how you have informed consent. And doctors are more than happy to be radically transparent with you on those issues.
Yeah. Absolutely. Always talk to your doctor. They're the ones who know you best. They know your child best, and they can truly address all your questions and concerns.
Thanks for joining us on From Bench to Bedside podcast. We're thrilled to have you here as we explore the intersection of science and medicine. Be sure to subscribe so you don't miss our upcoming episodes where we'll dive deeper into health topics that matter. Until next time, stay curious and stay informed.